Okay. Good morning, dear friends, dear brothers. I am Professor Sarica from Istanbul, Turkey, and it's a great pleasure to be among you for this excellent meeting. And before beginning to my presentation, my sincere thanks to Dr. Al-Hajeri, Dr. Al-Anizi, and also Dr. Al-Mahmid, and the all organizing committee members for organizing this meeting and inviting me, giving me this chance to present 2 lectures during this meeting. It's a great pleasure. Once again, cordial regards from Turkey, and also as the co-chairman of International Alliance of Urolithiasis, sincere regards from all our members. Over the next 20 minutes, it will be my task, this presentation, to talk about minimal invasive management of pediatric stones. We know that pediatric urolithiasis is something else. It's a multifactorial disease with high recurrence rates and greater morbidity when compared with adults. And when we evaluate the etiology, here you see metabolic problems may be responsible around 50% of the cases, which requires a certain true metabolic evaluation in all cases in order to prevent future recurrences and limit the number of procedures in the growing kidneys of these patients. It's a management dilemma because the procedures may have a possible adverse effects on the growing kidneys, small kidneys, significant recurrence rates, common underlying metabolic disorders, and cooperation among the involved departments. Pediatric surgery sometimes it's a task when compared with adults. There are some facts. Decision making is harder in these patients. They are more likely to pass stones than adults. We see it during the clinical practice. Even large stones can pass spontaneously in these cases, and stone composition must be kept in mind when we decide about the future treatment, further treatment. What are the aim? It's clear. Complete stone clearance with minimal or no complications, eradication of infection, and correction of any anatomical or metabolic abnormality in these cases. With this aim, we have to combine the most effective and minimal invasive surgical treatment, and appropriate prophylactic regimen should be installed. What are the options? Shock wave lithotripsy, uroscopy, and PNL. Beginning with shock wave lithotripsy, we know that first it has been applied in adults, and years after, depending on the experience gained, children, it began to be treated with this modality. However, today, we know that it has been not approved so far by FDA, this treatment modality. We have some advantages with this modality in kids. Children, they pass stone fragments well, and they don't require standing in the majority of the cases. IV sedation in all of the cases is enough maybe for the treatment now with the new type of lithotripsy. Small focal zones and less pain is an advantage. Better fragmentation rates could be anticipated in children due to the shorter duration of stone disease, greater stone fragility, lower impedance of shock waves, smaller body habitus, and also early mobilization of the kids. When we evaluate the outcomes, here you see if the stone size is less than 1 centimeter, around 100% stone rates could be anticipated. Even in larger stones, we will discuss it a little bit later with my dear friend. Here you see, again, 70% stone rates could be anticipated. So, high stone burden and multiple stones could be the responsible factors for lower stone rates. This is a nice study. It's old, but even in very young patients, Lotman, Shukla, and McLaury, they evaluated. You see the age of the children. They were treated with shock wave lithotripsy and stone-free rates. Highly, highly successful. This is one of our study performed in kids, and child's age is an important factor. And does it affect the outcomes? Yes. If the child is younger, as you see here, when we compare the younger and older children, in younger kids, we may have really higher stone-free rates, single session, and number of mean sessions will be less in younger children. How about lower pole stones? It's a headache in adults. We know it very well. Actually, high energy shock waves, they are effective. They are disintegrating, but when it comes to pass the stones, out of the body. Due to the location of lower pole, it's not so easy to pass them. But when we compare children with adults in terms of the success rates for lower pole stones, again, our results did show that children can pass the lower pole stones in a very highly successful manner with higher stone-free rates and lower complication rates when compared with adults. How about obesity? It's a certain factor for adults, but we evaluate this factor, our team, with the publication from my group, and it is not a big deal. A certain factor for kids, and kids with higher body mass index values also could be treated with high energy shock waves with higher stone-free rates. Here you see 94% stone-free rate versus 100%. Sedation is enough. A new study also from our group, in older children, there is no need for a general anesthesia if the child is older than 10 years. This is also another advantage for older children, not to let them undergo general anesthesia with IV sedation if it is appropriately taken with a dose adjustment. So this is a nice study summarizing the outcomes. Overall success rates 70% to 100% depending on stone size and stone location. Even in second calculi, 73% stone-free rates. Lower pole, you see, really successful. How about complications? 20 studies, and in the end, we see that all complications are in minor range when we evaluate them Clavian in the classification system. And in number one is the transient hematuria. Otherwise, major complications are not expected. Ureteric stones can be also treated in children very well. Here, you may see easily that stone-free rates may range between 76 to 100% in a successful manner. Retreatment rates may be higher, but when you evaluate the invasiveness of the procedure, second session, if the child is stone-free, it will be no task. This is a study, a recently published study coming from Turkey again, comparing the shock value with RIRS for stones sizing less than 2 centimeters, and in the end, the authors were able to show that active procedural sessions and number of anesthesia sessions was higher in RIRS. Procedural time and anesthesia time were higher in shock value group. Stone size was the most important factor, and similar success rates, shock value could be chosen as a good alternative in such stones. Going through the guidelines, here you see in the majority of the stones, particularly sizing less than 1.5 centimeter, shock value in children will be in the first place to treat the stones. That is inevitable, and let's keep in mind as the first, let's say, option. How about ureteroscopy? Ureteroscopic management of stones in children had a delayed adoption. Why? Because we needed to use large instruments in the beginning. Experience came from the adults, but in the beginning we were a little bit, let's say, in difficulty. Higher stone fragment clearance rate after shock value did lead us to perform shock value and lower incidence of stone formation maybe. But in the last 20 years, techniques refined, equipment improved, and we now have smaller instruments. Here you see 4.5 French ureteroscopes, semi-rigid ureteroscopes, and flexible scopes to treat the stones in kids. That is acceptable. Durability of equipment increased. Whole beam vac laser has been introduced. Now we have thulium, but overall clinical experience did increase. A nice overview evaluating the outcomes of semi-rigid ureteroscopy in kids. 15 studies with a huge number of cases, and in the end, the stone-free rates is around 80% to 100% with staged procedures. Dilation needed in a limited number of cases, and complications were again limited, like similar in adults. And for lower ureteric stones, shock value lithotripsy is in the first place, but also for upper ureteric stones, it will be also comparable with RIRS. We have flexible scopes now, and flexible ureteroscopy, beginning with Dr. Cannon in 2000's first series. Now, depending on the experience increased, we now perform flexible ureteroscopy in kids too. And here are the studies published so far. Stone-free rates are acceptable, higher stone-free rates with minimal complications can be expected similar to adult cases. Flexible ureteroscopy in preschool age children. Study from Turkey, Dr. Erkurt, and 65 cases. Preschool age, mean stone size you see here, and stone-free rates was 83% and 92% the first and second procedures. Complications were minimal, acceptable, and it's a good, safe alternative in these cases. In cystine stones, a study from my group, again, we treated the cystine stones in 14 cases. In the stone, you see the stone size. Ureteral access sheet was used in a majority of the cases. Double J stent was placed in 12 cases. Knee operation, minor complications in 2 cases only, and all cases were stone-free after a month period. This alternative can be applied in infants in preschool. So again, as this study from Turkey shows, with really higher acceptable stone-free rates in the end. When we compare RIRS versus shock value therapy for medium-sized stones, nice study published by Malkus and his co-workers, 16 children, group 1 shock value therapy, group 2 RIRS. After a single session, stone-free rates 70% for shock value therapy, 87% for flexible ureteroscopy. But think about the invasiveness. Passing the flexible scope through the urethra of a male child will not be so acceptable or easy, and we need to think about the possible consequences. And mean operative time, fluoroscopy exposure, and complications were similar, and after 3 months, you see, stone-free rates 93% versus 96%. Then, let's consider shock value therapy in the first place. Mini PNL versus RIRS. Again, for the same size stones, overall stone-free rates was not different, same with each other, RIRS and mini PNL, and mean number of anesthesia, you see here, complication rates were not different, and RIRS has a shorter operative time, fluoroscopy time, and hospital stay when compared with mini PNL. This is coming from the Scandinavian area, a summary maybe, 24 URS procedures, mean age 9 years, and large stone size 12 ml, and no intraoperative complication, and stone-free rates in the end were 90%. Shall we use ureteral access sheet in kids also? Yes, but we need to be highly careful. Available smallest sheet is around 9.5 French in diameter, and complications can occur. If we use it for larger stones, we will have the chance to have limited complications and higher stone-free rates. That's clear. But again, we need to be very careful. A nice study evaluating the ureteral access sheet used in children weighing less than 20 kilograms, I mean smaller children, 13 children, 16 procedures, and shock stone-free rates was achieved around 82% of the cases, and with auxiliary procedure it was around, in all cases, 100%. Minor complications and no ureteral strictures or reflux has been noted in any case in these cases. Summarizing the flexible ureteroscopy from all aspects in kids in this nice study, 5 studies, 250 cases, stone-free rates 76% to 100% with stage procedures, and complications, minor and severe ones, are really acceptable and limited. How about rigid ureteroscopy in kids for ureteric stones? Here again, we may say that stone-free rates really higher and acceptable. Safety and efficacy of ureteroscopy in this is a systematic review, 11 studies and 400, more than 400 cases. Complications are minor in nature. Stone-free rates are really acceptable, and ureteroscopy and laser stone fragmentation for this population is a safe and effective treatment alternative with higher stone-free rates. Guidelines again, it show us that it can be applied in renal pelvic stones with shock value therapy, so of course in the first place, and also for stones in all positions less than 1.5 centimeter. Lastly, going through the PNL in children, you know, it was first reported by Woodside and Scott in 1985, and we have also some concerns regarding the application of PNL children due to the long-term renal damage, smaller kidney size, relatively large instruments, radiation exposure, and risk of major complications such as bleeding and infection. But the indications are similar to adults, as you see here, and guidelines do show us that in larger stones, stone sizing larger than 2 centimeters, PNL will be in the first place, still in the guidelines. Complications are limited. A number of studies you see here, summary, and stone-free rates differ depending on the size of the stone and location of the stone between 68 to 99%. But over time, in the beginning, we used larger instruments in the growing kidney of the pediatric cases, and this was a major concern. When the miniaturization concept has been introduced into our clinical practice, mini PERC procedure, first by Jackman and his co-workers, has been introduced. Here you see the 12 French dilatation and 8.5 or 11.5 pediatric nephroscope. This was the first application of mini PNL in kids. And the first publications did show that it is effective, it is really minimally invasive, and we need to perform this procedure in kids in order to limit the risk of invasive complications. And over time, the results of other publications have been seen in the literature. Here you see 20 mini PCNL and 11 cases had second stones. And total success rate was around 92%. The primary stone-free rate was around 84%, and it raised after 91% treating the residual fragments. When we evaluate the RIRS with mini PNL, comparable data could be accepted, but the stone size will be larger for mini PNL, and we need to think about the complications of this surgery. So mini PNL continues to be the best choice for stones, for larger stones in kids, depending on the results of this study. Further miniaturization of the equipments did bring some certain types of treatments, beginning with ultra mini PNL with from India, and in this modality they used 13 or 14 French sheet, and in the end they evaluate the outcomes, really minimally invasive, no bleeding, and outcomes are really excellent. Up to 2 centimeter, the stones in the kids could be treated in an excellent manner, particularly lower pole stones. Later on, further miniaturization did bring the super mini PNL from China, a good friend of us, Professor Zheng, and the size of the instruments went down further. Here you see 10 to 12 French nephroscopic tract and 7 French inner sheath. What about the nephroscope? 4.8 French. And the main characteristic of this treatment was active irrigation and active suction. Active suction means bringing all the fragments out as they formed during the laser fragmentation. You see here the system, and you are irrigating.
Time, please. Time.
Yes, okay, I'm finishing. And by using SMP in pediatric cases, its stone-free rates, tubeless PCNL, totally tubeless PCNL rates were really high. Micro PERC was another modality, but it was a little bit dead word for me, not popularized, but in some centers it's being performed. In experience, and it will be the treatment of choice, particularly for children. A study from Turkey did show that really limited complications and highly successful results. We can apply supine PNL in kids. It's growing and growing with higher success rates and limited complication rates. It will be the treatment of choice in the future. Last but not least, in the beginning we performed PNL with adult-sized instruments, and I may say that this is a study from Turkey, and this is a study from my group. I may say that if you don't have mini PNL instruments in your area or no experience, you may go further. You may perform standard PNL in experienced hands. It will be successful with limited range of complications. So we need to be very careful. We need to use the minimal invasive alternatives, shock value alternatives in the first place, and we need to evaluate the metabolic position of the kidney, status of the kidney, in order to limit the recurrence rate. Thank you so much for your kind attention.
Thank you, Professor Kamal. We will leave the question at the